Next, I'd like to introduce Mr Nigel Scott. He's a consultant colorectal surgeon at Royal Preston Hospital, and he's also the National Clinical Lead for the National Bowel Cancer Audit Project. My first question is, how does the national screening for bowel cancer work?
Well, bowel cancer is a very common problem. It affects about 35,000 people a year in the United Kingdom. And that means that one man in 18 will get bowel cancer in his lifetime, and maybe one woman in 20 will get bowel cancer. The problem at the moment is that when we see symptomatic bowel cancer in the clinic, it tends to be fairly advanced disease, Dukes B or Dukes C disease, and we see very few patients with early disease. When we do population screening with fecal occult bloods, we're actually able to find a large group of asymptomatic patients that have much earlier cancer, sometimes just polyp cancers and sometimes Dukes A cancers. The early cancers, if we resect them, we could resect them with something like a 95% cure rate. And we know that when we apply screening to a population, that because we're finding earlier cancer, we're resecting it for cure, that we actually reduce the number of patients or the number of people who die from bowel cancer in that population by about 16%. So bowel cancer screening finds people with early cancer, cancers that we can resect, and that makes a real difference to the survival of the population in terms of curing bowel cancer.
From your perspective, how do we as healthcare professionals increase the uptake of screening and hence early detection of bowel cancer?
Well, I think this is quite a wide cultural issue, because bowels and poo are not the most sexy issue in the public's minds. And in fact, there's quite a lot of people, particularly in the group that we're targeting, which is 60 to 69, who would instinctively look upon anything to do with bowels as being something that they didn't want to get involved in. And I think in many ways, to try and improve the uptake of bowel screening, we've got to get more information into the wider public's hands about the fact that bowels are a necessary part of our life. Everybody's got bowels and uses bowels. That if there are problems, they need to come forward early with the symptoms that they might have. And particularly when it comes to bowel screening, that when that invitation letter comes and they get the test, to have a bowel screening test, that it can make a real difference to people in terms of finding early bowel cancer and bowel cancer that would be at a stage that we could cure it with a surgical resection. So I think it's a whole cultural message of that bowels are acceptable things to talk about, that problems with bowels are things that we should talk about and go and see the doctor about if they are significant problems, and that there are things that can be done to get rid of serious problems such as bowel cancer.
What are the early signs and symptoms of bowel cancer?
Again, I think that's been pretty well worked out, and unfortunately there are things like changing bowel habit to loose stools. That I think is one of the most significant things that people complain about. So if somebody who's 60 plus and comes with an alteration in bowel habit, that is certainly a really significant symptom for bowel cancer. Rectal bleeding is also a significant symptom for bowel cancer, particularly if it's not associated with anal symptoms. So if somebody has rectal bleeding without any swellings or itchiness or anal symptoms, then that's a significant symptom for bowel cancer. I think those two things together, loose stools, bleeding without anal symptoms, patient 60 plus, that's the kind of person who should be coming along to the clinic for assessment to see if those symptoms are due to a bowel cancer.
Please could you share with us what happens in a lower gastroenterology 2-week assessment clinic?
Well, what happens is that the patient comes, we do the traditional clinical method. There's a history taking, abdominal examination, rectal examination, and quite often a rigid sigmoidoscopy in the clinic itself. But ultimately, if a patient complains of a significant bowel symptom, we have to examine the large bowel. If the symptoms are just rectal bleeding without any change in bowel habit, then we're usually happy to investigate the individual with a flexible sigmoidoscopy, and that's a good enough test to look along the left-hand side of the bowel and say there's no significant problem behind the rectal bleeding. If it's a change in bowel habit, we definitely have to look at the whole of the large bowel, and for most people that means a colonoscopy, or occasionally a combination of flexible sigmoidoscopy and barium enema. If we see somebody who's got a lot of medical comorbidity in whom a colonoscopy might be damaging and might be difficult to essentially put up with, then we often do an abdominal CT scan, and abdominal CT scan or CT colonography is a way that we'd look for a bowel cancer in somebody who had a lot of comorbidity that we didn't think would do very well with colonoscopy.